Hi everyone. So I know that you have a med-surg quiz this week, so I'm trying to help out a little bit and give you a recording. So basically, I want to go over its chapters 26 and 27, which is management for patients who have hypertension and vascular disorders. So the first thing, and I think one of the most important things, is hypertension because it's one of the most common chronic diseases in the United States for adults, which is high blood pressure. And high blood pressure or normal blood pressure would be 120 over 80. So as we start getting a little higher than that, as looking at my chart, 120 to 129 for the top number or the systolic blood pressure, and less than 80 for the bottom or in the 80s, we're getting a little elevated, okay? So I would say once you get to 130s, right, and 80s or greater on the bottom, and 140s and 140 over 90, things like that for blood pressure, we're looking at hypertension, okay? Because normal should be 120 over 80 or less, but if we start getting more than that, such as a systolic of 130 and a diastolic of 80 or greater, we're looking at hypertension, okay? But what the problem with this type of disease is that a lot of the time you're not going to have symptoms. So a patient might not know they have undiagnosed hypertension. They might not know that they have it, right? They might go to their doctor and their blood pressure might be elevated and they might say, "Oh, I've been stressed out a little." And their primary doctor might say that's okay. So a lot of the times it goes undiagnosed, and that's a problem because there's no symptoms. You don't usually feel the sorts of symptoms that you would for other diseases. So that's why they call it a silent killer because it's usually asymptomatic. And one of the races that is most affected by hypertension or has the greatest risk is if you are African American. And something that I also want to go over is that there's two types of hypertension. There's primary or secondary. Primary means we don't know why the person has the hypertension. There's no specific cause. And secondary hypertension is when somebody has something, right? So, let's just say this person has heart failure, then they might get secondary hypertension or things like that. Okay. So it really just depends. And some causes can include renal disease, pregnancy, and sleep apnea for a reason for why a person might develop secondary hypertension. So, like I said, if we're trying to look at our questions, a blood pressure of 130 over 80 and greater would be looking at a diagnostic criteria for hypertension. But in order to sort of diagnose or figure out, hey, if this person really has hypertension, it's not going to be the one time you take the blood pressure. You should take it twice. Taking the blood pressure 2 times would be confirming a diagnosis for hypertension because if you take it once and you take it again, and it's the same thing, then it looks like this person will have hypertension, right? So that's always a rule of thumb. If you take a blood pressure and it seems high, NCLEX question, retake the blood pressure again, okay? So other things include just for NCLEX related questions, if it says in the question that the person has hypertension, and their blood pressure is like 130 over 80, that would be considered normal for that person. So if it's said to identify any sort of abnormal findings, it wouldn't be the blood pressure because the blood pressure is an expected finding because they have hypertension. So, as I said, for hypertension, you don't have symptoms other than the elevated blood pressure. And we try to diagnose that by having 2 confirmed blood pressure readings. Usually at 2 different times. So like I said, you could be stressed one day and come back another, but just know 2 different blood pressure readings. Now, usually no symptoms, but you need to know this. This relates to the pathophysiology, but also for risk factors and potential problems that a patient might have, okay? So hypertension or untreated hypertension that's left and nothing is being done to prevent it can lead to retinal changes or changes in the eye. So if a patient says, my vision's been really blurry, and you take their blood pressure and it's like 140 over 90 or 150, okay, we're having a problem. They're having symptoms. They can have renal damage, which means if they can have renal damage, NCLEX question, I want to look at the lab values. I want to look at my bun and creatinine levels because that tells me that they might be going into potential renal failure. Okay, so hypertensive patients, we got to tell them, you know, have regular eye exams. Okay, renal damage, really look at those lab values when they get their annual their blood labs. Okay, we want to look at that. They might have a myocardial infarction, so we should tell them signs and symptoms of what um a heart attack can look right? Like chest pain, pain that radiates from the left jaw down to the left arm, things like that, okay? Also, it can cause cardiac hypertrophy or the heart to increase its work and a stroke. So I would say, okay, I know that normally for a person who has hypertension, they don't have symptoms. But if they do, we might see symptoms in the eyes because it can cause retinal damage, symptoms in the kidneys because of kidney damage. It might cause heart problems. So we really want to watch out for, cardiac abnormalities and stroke, indications of stroke, okay? Now, stroke, just for word of thumb, is usually like slurred speech, things like that. Okay, they might feel weakness on a side of the body. That can indicate a stroke. So, other things that I want to mention. Okay, so when you are measuring blood pressure, you need to look at the cuff size and you need to get the correct cuff. Okay, so for a larger adult, you need to take a larger size cuff than, let's just say, the normal adult cuff. But that's why it's really important to know that, because if you give them the wrong cuff, the blood pressure is going to be extremely off. So if it's too small or too tight, it's going to increase that blood pressure. And if the cuff size is too big, then it decreases the blood pressure, right? Because if the cuff is loose, you're not going to get a good reading. And if it's too small, it's going to compress the arm so much and make that blood pressure way higher than what it should be. And as I said, we want to confirm a diagnosis by using 2 blood pressure readings. And we look at their lifestyle, right? Because before we go to medications and medical treatments, we want to do always priority is the least invasive interventions, and that includes educating them on lifestyle modifications. And if that doesn't work, then we start thinking about prescription medications, okay? But they still should be doing things like eating a healthy diet and exercising, even if they're taking medications. Risk factors for hypertension, as we said, African Americans are a race that are put at a higher risk, advancing age, chronic kidney disease, especially because it can cause renal failure, diabetes, drinking too much, a family history, if you are of male gender, hypercholesterolemia or high cholesterol levels. If you're overweight or obese, that increases your risk for hypertension. A poor diet or a diet rich in like those processed foods and high salt. A sedentary lifestyle, meaning you're not moving around too much, also increases your blood pressure. Smoking or tobacco use. And a good NCLEX tip is to always assess their readiness, right? Because even though you want to educate patients always, sometimes they're not ready to quit their habits. So we want to see their thoughts on quitting, especially when it comes to smoking. So we'll ask them, have you ever thought about joining a cessation program, right? We want to see where they are at in terms of wanting to change their behaviors. Other risk factors include stress and sleep apnea. And most of these risk factors are a lot of the risk factors for a lot of other cardiac related disorders. Now, we also have abnormal findings. Now, this is when, like I said, blood pressure gets too elevated, untreated for such a long time, and we have things like absent or weak pulses, additional cardiac sounds, retinal hemorrhage, distended jugular veins, and a renal artery bruit, which is kind of like a little sound that you hear, which isn't normal, okay? So it's a sound that you're going to hear in the arteries. It's going to sound a little off, okay? So if we have in our physical exam findings a patient with hypertension and we see absent or weak pulses, any additional cardiac sounds, right? Their eyes start becoming bloodshot and their jugular veins are distended, then we might be having a cardiac issue, okay? Or a retinal issue because we said that hypertension or undiagnosed and untreated hypertension can lead to retinal damage and renal damage, okay? So if we see any of these signs, we really need to notify the provider and get in some really immediate interventions. And now, right, as I said, thinking about all of the assessment findings, thinking about what we can see in our patient, in our assessments, we want to look at their history, right? Look at the physicals, the eye exams, those lab values that I mentioned, bun and creatinine, especially because of the renal damage, EKGs because it can affect the heart, right? Or an MI because we might have that ST elevation, which indicates a myocardial infarction. Okay, we want to also, like I said, assess for targets of organ damage. Are they having visual disturbances? Remember, stroke, so they might have altered speech. Headaches and dizziness and balance problems can all be signs of hypertension. So if they're having these things, they're becoming symptomatic, and that's an issue. Okay, because remember, it can lead to MI, heart failure, retinal hemorrhage, renal insufficiency, and all these problems, okay? So if we see symptoms, they're related to targeted organ damage, okay? Now, medical management of hypertension. Like I said, we're trying to maintain a blood pressure of less than 130/80 because 130/80 and greater means that they're in a hypertensive state, okay? So that's why when we give our blood pressure medications, we must assess an hour later, right? Did their blood pressure drop from what it was before, okay? And that's why they can definitely ask you on your exam about those antihypertensives and how to look at blood pressure medications in the management of hypertension. So, lifestyle modifications. Okay, this is our priority interventions, telling them about the DASH diet. Okay, and I think DASH is like diet associated. I forgot what it's called, but I know the H stands for hypertension. So I know DASH means that it's a diet used to treat hypertension. Okay, so things that this diet does is it tries to lower sodium intake because we said sodium or increased sodium intake can cause hypertension. So we want to watch out for foods and high in salt, so no pickles, no canned foods, no meats like those red meats like or those cold cuts like salami and things like that, cheeses because they're high in salt. Regular exercise, reduce alcohol consumption as that can also increase blood pressure, and weight reduction. As we said, obesity or being overweight increases the risk. So if these are lifestyle modifications, we're basically telling them decrease your alcohol, decrease your sodium intake, decrease your weight, increase your exercise, and we also want to help them manage stress because stress can cause high blood pressure. Okay, so medications, right? We can give a thiazide diuretic, which diuretics are usually given first. Okay, then we can give beta blockers or alpha 1 blockers, like remember that prazosin, beta blockers like metoprolol, vasodilators, ACE. There's a bunch of antihypertensives, okay? So you need to know the management of those medications and what to do because they can be easily asked on your exam. So if this is not familiar to you or you don't remember the risk in giving any of these types of antihypertensives, you should go back and look at them. But how do we know, right, if our patient is doing well in managing their hypertension? Well, we look at the disease management. Are they maintaining that perfusion? Are they having any manifestations? Okay. How are they doing with their lifestyle modifications? And if they're taking their medications, they should be writing down their blood pressure. And we could see it based on the recordings if the medications and the treatments are working. Okay. They're not having any symptoms. They have normal bun and creatinine levels, okay? Palpable pulses, because as we said, absent or weak pulses indicates a problem. And are they managing those diet changes? They should keep a food intake journal. They should be writing down the things that they eat and intake and output so that we know as providers, like, hey, and the nurses, are we looking at a diet that's going to help promote wellness and not increase the risk factors in hypertension. We're also looking at mainly, like I said, those diet changes and lifestyle modifications first. And then we're going to tell them, hey, take your medications, and they should be monitoring their blood pressure every day before and even after taking their medications to know if it's working, okay? So those are some NCLEX-like things, okay? Now we're going to get into peripheral vascular disease versus peripheral venous disease, okay? They are very different. So if we're thinking arteries and you're thinking about the pathophysiology or how the arteries transport blood to the body, right? So they leave the heart and bring it to the organs, okay? So it's going down the body. Whereas the veins need to travel upwards to the heart, okay? So there's different levels of gravity that are affecting how our body receives blood and how the heart receives blood, okay? So in artery, we're thinking about taking blood away from taking it from the heart to the rest of the organs, so it's traveling down, okay? So we have something called intermittent claudication, which is a resting pain. That is an indication that they have an arterial disease. Why? Because remember, the arteries are bringing the blood down. So they're bringing it from the heart to the rest of the organs. So if they're resting, they're not moving, and those arteries are not really being able to perfuse. They're not really able to perfuse the body as well. So if they're not able to do that, they'll have pain as they're resting, okay? They also have ulcers with regular borders. So the ulcer is not going to look weird. It's going to be like a regular circle or however that shape should be. And you normally see them on the big toes. That is a big indicator that it's an arterial disease and not a venous, because the big toe will have an ulceration and it will be necrotic or black, because arterial means if we're having a peripheral arterial disease, that means we are occluding or there's a problem with the arteries. So there's a problem with perfusing blood to the rest of the body. If that is the issue, that means they're not getting perfusion properly, so they're going to get necrosis, okay? And another indicator is that they have no hair on the toes, because the hair growth is due to the fact of good perfusion. So if you have no hair on the big toes, you see that on your patient, that's an indication that they might have peripheral arterial disease, okay? Other things include pallor and pulselessness, okay? Pallor means like the skin is more pale, okay? And that is because of the lack of perfusion, because the perfusion brings the color to the skin. The pulselessness is because pulses are from the arteries. So if the arteries are having a problem, they might not have pulses. Their skin's going to be cool and dry, and we call that polychiothermia. And as I said, those hair loss on the toes, and the legs must be dependent, meaning they should be in a sitting or a neutral position, because the legs need to get the flow to the arteries need to get the flow to the rest of the body. So the arteries can't do that if the legs are elevated. They need to be down, okay? That's why exercise and movement is good for these people to help promote circulation. Whereas peripheral venous disease, we're talking about pain in the veins. So this is more of a dull and aching pain. And remember, the veins travel from the body to the heart, so they work against gravity. So the ulcers in these would have irregular borders, and you usually see them on the ankles. These are beefy and red, and they have these irregular borders. And they usually could be like a brown yellow color, right? Whereas arterial is a black color. And they will have also edema, unilateral edema. So if they have edema in one particular leg and like the lower extremities, that is a potential sign of peripheral venous disease. Pulses are going to be present here because this is not an artery problem. Arteries cause the pulses. So the arteries are fine, it's the veins, but they might be hard to palpate because of the edema. They are warm instead of cool because the warmth comes from arterial perfusion, which they have in PVD, and they don't have that in PAD. So they're going to be warm. They're not going to be cold, okay, because they still have circulation. they have that yellow and brown discoloration. But because this is the veins and they work against gravity, we need the legs to be elevated so we can promote that blood flow back to the heart. Okay, so those are major differences between PAD and PVD. For PAD, diagnostic assessments include an MRA, which is a magnetic resonance angiograph, a segment systolic blood pressure management, but the one I would want you to know is this ankle brachial index, where you're comparing the blood pressure in the arms to the legs. That's going to kind of tell us if they're having an arterial issue, because every extremity should be the exact same. So we're going to compare the arms to the legs to see if they have peripheral arterial disease, because if they're not and that blood pressure is much lower in the bottom or something like that, there's an issue. And exercise training, okay? Now, interventions, we're talking about arterial. So we want to promote vasodilation. So we might give a vasodilator. So we got to watch out for that blood pressure, right? Exercise and positioning, they should be moving. That's going to promote circulation, and constant repositioning is going to help promote circulation, okay? Drug therapy like anticoagulants or antiplatelets prevent any clot formation due to that vasoconstriction or the problems that we get because there's no arterial perfusion, okay? We might have something called arterial revascularization, which is basically when we open up the arteries to try to help them perfuse. We might have a thromboectomy or an embolectomy, which is a removal of clots, and that's because if the arteries, like I said, aren't working properly, there's an increased risk for clots. And no tight clothing. That is so important. Out of all of these, I would remember exercise and constant repositioning. We want to promote vasodilation, okay? And we want them to have anticoagulants or antiplatelets, and note tight clothing, because one, that can increase the risk of clots, and two, it's going to cut off the circulation even more, increasing the problems with PAD. Now, a good little tip to know or remember for your med-surg exam would be the 6 P's of arterial insufficiency, which are pain, pulselessness, parasynesthesia, pallor, paralysis, and polychilothermic. So the first P, right, we said pain. So they're going to have that pain. They're going to have that intermittent claudication. Pulselessness, because they're not having perfusion. Parasynesthesia, or pins and needles, because it's that numbness feeling from that vaso-occlusion or the lack of perfusion to organs. Pallor or coolness, or that pale coloring, right? The coolness is the polychithermia, but that pallor is in part of the vasoconstriction that they're getting. So they're going to have pale like skin, okay? Paralysis, or it's really hard to like move because of the arterial problem, and coolness, okay? So I would remember these 6 P's. It's really important. Now, for PVD, or peripheral venous disease, symptoms or assessment findings that will help me know, do they have a history of venous thrombolytic embolism, right? Are they having, right, like a DVT or something like that? Do they have that? And risk factors include, right, a sedentary lifestyle, and they don't really exercise much, okay? If they have a sedentary lifestyle, they're at risk for clotting, okay? And they might have calf or groin pain. That's indicative of potentially a DVT. And that onset of unilateral swelling, which we said is a symptom from potentially having a problem with the veins. So we could have swelling. And that's because the blood flow is pooling in those veins and it's not able to get back up to the heart. So we have edema. Now, we can do different things like Doppler studies or MRIs, but I would really just know the signs and symptoms of each and the important assessment cues for PAD and PVD. And I would also know that risk factors or causes for both of them include a history of smoking. So that's something else that we want to look at. A history of diabetes for each of these disorders, a history of hyperchloremia, and hypertension, okay? Because all of these can cause problems in the arteries and the veins. Then we also have something called Raynaud's phenomenon, and Raynaud's phenomenon is a vaso-occlusive arterial disorder, which is basically saying that the vessels are closing, and that usually happens in the fingertips or toes, but those are the places. So we're looking at the fingers and the toes, okay? And it could be associated with an underlying disease or primary, meaning we don't know why they get it. And it usually is seen in young women. Manifestations, we're talking about arterial vaso-occlusion. So we're talking about, right? Think of those 6 Ps, right? They are going to have some numbness, some tingling, a burning pain, or that like parasynesthesia, right? And color changes, right? They might be pale and things like that because of the vaso-occlusion. That's what they mean by color change. Think about it. It is arterial. Causes are usually cold and stress. So with these patients, we want to tell them to avoid being in the cold, avoid being in the stress, like being in stressful environments, and being really careful with injuries in the hands and the fingers and the toes. Okay. For varicose veins, we are talking about an issue with blood getting to the heart. Remember, we're talking about veins. And veins can be, or varicose veins are caused by venous stasis, or the veins not being able to carry that blood flow to the heart. So tight stockings and things would not be good because they would make it even harder for the veins to shoot out blood back to the heart. Crossing the legs at the thighs causes varicose veins because the blood is going to be pooling at that level and not really being able to send it back to the heart. And sitting or standing for long periods of time can also cause varicose veins. And a risk factor for this is obesity or being overweight, okay? We want to elevate the legs. As I said, if it's a vein disorder, we need to elevate it to help promote it to get back to the heart. And that's just based on the pathophysiology or how the veins get blood from the body to the heart. We want to encourage them to walk 30 minutes a day if there's no contraindications, and that is a CDC recommendation. We want to wear graduated compression stockings. Now, these aren't like tight clothings, they actually help promote blood flow. So something else like in these venous like issues, we see things like in those DVTs, you might hear something like those compression socks or the DVT boots or things like that, or something they're called something like that, the little boots. Those actually don't hurt them, they actually promote circulation. So even though they say compression, they're not compressing it like that. But with these type of things, we typically do avoid really, really tight clothings and things like that, okay? So, like I said, we're talking about arterial versus venous. So when you have those issues, look, is this an arterial issue? Because arterial issues are going to present with the similar symptoms, right? Those 6 Ps. And if it's veins, we're talking about potential DVTs. We're talking about problems with pooling the blood back. So there is issues there, and the management is going to be similar to other management of other venous related disorders. So that's how I would think about it in terms of your med surg exam. And I hope this helped.